moving toward the next session, we have Dr. Seemab Shaikh with us. He is a founder president of IASSA, HOD of Inamdar Hospital, Pune, and consultant ENT surgeon at KM and Sahyadri Group of Hospital, Pune. Sir is a well-known name in ENT, snoring and obstructive sleep apnea nationally and internationally. He has about 30 years of experience and has conducted innumerable surgeries in all fields of ENT. Some of the key surgeries he has performed are OSA, snoring, micro-ear surgeries, endoscopic sinus surgeries, and voice-related surgeries. He has credited for pioneering the field of obstructive sleep apnea in an organized manner in India. He has traveled the length and breadth of India, conducting various surgical workshops and live talk on multiple platforms. He was chosen as the founder president of Indian Association of Surgeons for Sleep Apnea. He has various national and international papers to his credit. He is also a mentor for IASSA Fellowship Training Program for Snoring. Today, sir is going to deliver his talk on clearing micro concept in OSA while also clearing the concept of OSA. Over to you, sir.
Thank you, Dinesh. Good afternoon, everyone. It's a big thank you to the team Alembic and thank you to everyone out there. Without further ado, I would like to start sharing my screen and talk. It's wonderful to have heard a lot of people out there. We've not been seeing each other very often, but I heard so many of the regular voices of all our people. So if somebody can just give me a shout and say that my screen is visible, I would like to start off. Is that visible to everyone?
Yes, hello, Dr. Seemab.
Yes,
your screen is available and seen.
Thank you. Wonderful to have you with us too. So my disclaimers right at the beginning. I'm not being reimbursed for this talk. My talk is in complete confirmation with the new latest NMC guidelines now. And it's a bit of a repetition because Professor Carl Hammond, from whom I actually trained from in Germany, always told me this. And he said, when you're dealing with non-otology, non-rhinology, non-laryngology subject, you've got to really, really drive it home hard. You have to be repetitive and you have to keep driving the message hard. So based on that kind of a background, what I'm going to try and do today is remove some misconceptions for y'all and try and clear some other concepts for y'all. If I'm able to do that by the end of this talk, then I'm going to be a happy person on this Sunday afternoon. This is what most of our people were doing very often. Many years back, this was the standard operating procedure for snoring and OSA surgeries. And it was always seen by most of the people who were doing it that the patients post-operatively were all doing well. Nobody really had a problem with these kind of surgeries, even in the post-op issue. Till the time when Sher et al. Came up with the classification, the AHI indexes, and they started outlining obstructive sleep apnea in a particular manner. And I'm going to try and give you a perspective as to what happened. So this is what Sher et al. Told us.
Ye hai NASA's most ambitious project ever, Juno, the spacecraft on a 5-year mission to discover Jupiter's secrets. Juno's scientific payload includes a color camera that will give the world the first ultra-wavelength microwave radiometer. In addition, it also has specially designed no cameras, please, ultra-high-speed engines that will take it to Jupiter in just 1 year. Any questions? Yes. Kitna deti hai?
For a country obsessed with mileage. That's exactly what was happening. We did so much. We were trying to do surgeries, we were trying to give results, and we were only being questioned on the AHI. And when they said AHI and they said, okay, AHI is not conforming to our standards, they went ahead and said that, okay, CPAP machines are the gold standard, and it was put down in literature. Now, this was at the time when a lot of our people were finding that the surgical results were extremely good. So here was a bunch of physician group telling us that, listen, the surgeries that you're doing are not conforming to the AHI index that we've proposed. And as a result, your surgeries are not successful. Where we need to start thinking is this: if this is where I want my surgical cure to be at, And if I have a patient who's come to me somewhere at this stage, and I'm doing some surgeries based on my complete evaluation and diagnosis, and I bring him to such a situation, sorry, where does this not make my patient better? Is this not good enough for my patient who came from this stage to this stage? So what are we talking about here? The biggest controversy that we've got to get out of as a surgical group, and trust you, I'm not talking here as a surgery versus a physician or a surgeon versus a physician. I'm trying to get a very comprehensive attitude about OSA and the goals of treatment. So if my AHI does not come down to less than 20 or not less than 50% pre-op, but my patient is doing well and my patient is happy with the quality of life, then am I not achieving a so-called benefit to the patient? Do we ask our asthmatics whether they get cured? Don't we just give them a good quality of life and maintain the quality of life issues? So that's exactly where we need to be targeting at, and not looking at just the AHI, because if we encompass something like a sleep goal, which is now being propagated by Kenny and Brian from Canada, Kenny from Singapore, all of you all on the international circuit will know them, who have mentioned that we use each and every criteria and not just an AHI. So we're going to be looking at the BMI, the gross weight, oxygenation, AHI. We are going to look at the latency of sleep onset. We're going to look at the quality of life score. And this gives us a much, much better perspective to the improvement in sleep apnea rather than just stating it at AHI. And definitely it makes it a little bit more complicated when we're trying to understand this. But at the same time, it gives a much more detailed and a holistic, comprehensive way to, kind of get the criteria in place to treat AHI. This AHI thing was an issue again, which was brought up, and they said that, okay, they classified it and said 25 and above is a severe category, and anybody with a severe category has to go in for a CPAP machine. But you just saw today morning, Dr. Haldipur operating on a case where he cleared the nasal obstruction for a patient who was a patient of sleep apnea also. Now, obviously, this makes a lot of difference. His AHI may have been very high, but if there is an obstruction which is easily removable. So I like the statement made by Dr. Haldipur. I've always liked that. He said 90% of the people doing 90% of the surgery across 90% of the country. These are the people that need to understand. For the rest, there's always OSA platform. So this talk is probably targeted to those people to try and make them realize that surgery is definitely a good option, provided you're able to find out the level of obstruction. So AHI should not limit you, because if you're able to identify the level of obstruction, then AHI is of not much significance to us as ENTs. Yes, AHI is important when you're doing the surgery. The anesthetist may need to know the lower saturation levels. We also need to know whether there's central apnea or not, because if there's central apnea, then we are not the right people to be treating that particular patient. And again, the BMI. Now, it stands to reason that obviously greater than 35, you want to avoid it as the first choice. You don't want to really do that, because a lot of us obviously understand that a high BMI is going to cause a compression of the airway at some level or the other. But if you are able to, just like the case in the morning, once again, I will quote, if you are able to talk to the patient and talk about the issues of morbidity and the willingness to be operated with realistic expectations, then I don't think a BMI where the patient's weight was about 114 kilos or so is going to be an issue for you to be operating on the standard non-dynamic static obstructions, as we call it. Now, diagnosing the OSA was a very simple thing, physiological and anatomical. We as surgeons will look into the obstruction sites. We do that with clinical effects, scopy, and imaging. But in the scopy, we have a pretty different kinds. You've got the FNLPs, you've got the flexible awake ones, you do a Muller's, and you also do a DICE. Sometimes in a scopy like this, when I'm seeing it inside, the obstruction is far too easy to be able to understand. So this is like really not that difficult. It's a no-brainer kind of a thing. You pick it up and you're able to understand that. But then there are controversies with the use of the scope that we have. So when you use an awake scope in a lying down position, the biggest situation that we have is, oh, it's not near normal, it's in awake state. But then I always recommend that at least do it as a routine. That should be your first point of examination in the OPD. If you have a scope with you or an access to a scope, and you can couple that up with a cine MRI later on if it's available, and that will give you a very, very good idea of the airway in itself. The Mullers again had a problem with not being exact and not being reproducible, but it's definitely not something that should be written off, because you will be able to identify clinically to a large extent, and that's been corroborated by studies, that the Mullers will give you a pretty good idea about the base tongue. And mind you, both these are basic OPD investigations. There's not something that you're doing out there which requires a lot of intervention there, like the dice. Now, the dice is always spoken of to be unphysiological. It does not tell us about the stage of the sleep. And if you have probably just a little bit of extra dosage of the propofol or midazolam or whatever you tend to use, then you might be overdoing the whole thing. But that has become much lesser now with the use of Dexmed and with the use of an intra-procedural PSG. Now, DICE is something that I'm going to come to in a lot of detail at a later date to remove some ideas that people have. But this is why we started doing intra-procedural PSGs. So I have endoscopy that I'm doing under sedation, and I'm also doing a PSG on table, which tells me at what level of sleep, because this was the major objection that the non-ENT group had to us when we were talking to them about surgery, and they said, oh, you can't really find out the level. So I started doing this. And then we started classifying DICE. It became a little better. It's no longer just classified as two analysis, but it's classified with the third type also, where we talk about AP and lateral. And we're trying to get it to be very standardized, where we talk about like the TNM classification. So if I'm sitting in any corner of the world, or my colleague is sitting in any corner of the world, when we talk to them with saying V1 AP O2L T0 OE0, he knows exactly what I've looked at into the DICE and what I've tried to find out. So that's a velum anteroposterior partial collapse, that's an oropharyngeal lateral collapse complete, that's 2, and tongue 0 and epiglottis 0. So that gives us a very much better classification of the DICE now. The imaging part, we had 3 parts. We have the cine MRI, which I've been tom-tomming across the country since quite a few years. There is now CBCT, which I've begun to start doing. And the CBCT, if you can see here, definitely also has now landed up with the volumetric evaluation and not just simply just the cephalometric part. The cephalometry nowadays can still be used, although it has very limited role generally. But when you're dealing with a bony cage abnormality, then it is this very cephalometry which can tell you the distances of the bones, which can tell you the angles sometimes that you need, and the thickness of the bones that you're dealing with. The cine MRI, like I said, gives you a very, very clear-cut vertical as well as a horizontal AP mediolateral obstruction levels, which are at different levels, and also the fact that you can actually note and measure the distances and keep them documented for pre and post-op evaluations at a later date. So this is where the problems can come in. Cephalometry, like I said, we restricted to bony cage. The cine MRI, although it's a little difficult to sleep in that and you don't know the stage of sleep, you can use it in conjunction with the scopies and you can have the measurements from it, because logistically speaking, it is quite impossible to do a cine MRI with an in situ polysomnography together. It's logically not possible. So, and in fact, none of the investigations are really to that effect where we'll be able to give you the complete picture. So we have reached an evaluation consensus where we talk about recommended and we talk about mandatory. We say that the level 1 PSG, if possible, has to be very, very important. We talk about at least doing a level 3 minimum before you actually get into doing any kind of work for OSA. We talk about doing either a DICE for those who want to do a DICE, or at least do an awake FNLP with a dynamic MRI before you actually tend. So this consensus is quite clear, has been published. should not have any kind of controversies with that at all. The important other questions that are generally asked out of a lot of workshops that we've conducted are related to palate, and I'm going to come to that in a bit, but the controversy is whether to try and do nose, nasopharynx and palate. So a lot of us today, when we do our nasal surgeries, do not do packing. A lot of us have started using splints, have started using quilting sutures, but even for those who are not doing it, even if you do a nasal surgery with a palate and you're able to pass a nasopharyngeal airway, you can still pack the nose with Avalon on both sides, keeping the nasopharyngeal tube in situ. And this can make the patient extremely comfortable post-operatively. So you'll see Avalon being put on both sides. And you will see how comfortable the patient is on extubation with that nasopharyngeal airway in its place. So there is really no issue to doing a nose and a nasopharynx together. And when it comes to a palate with controversies with excision or reconstruction, it's obviously now the days of reconstruction. Nobody really wants to do excisional work. Things have become much, much more easier. And the selection anatomically has become very methodical. What do you do when you have a very thick and bulky palate? That's where the zeta actually comes in, because the UP3 really doesn't have that kind of orientation or the results that are there. So let me take you through what happened with the UP3. So this was what was the UP3. You excised this entire thing and kept it, and you realized that over a period of time, it wasn't giving the required results. And then we started doing something different. We realized that it was the palatopharyngeus, which was possibly the one that was responsible for the lateral pharyngeal wall. So you pulled up the palatopharyngeus and got it onto and sutured it onto the soft palate here. That was the relocation part. Then we realized that probably that was not enough. I beg your pardon. So we thought that, okay, let's pick it up from the palatopharyngeus and bring it and hook it onto the pterygoid hamillus, which is a stronger structure, and we'll be able to get much more expansion. Now, again, over a period of time, realized that, okay, this is not working that well, and then thought that, okay, let's bring the palatopharyngeus and hook it onto the entire pterygomandibular raphe, which is the lateralmost structure and a pretty solid structure. So if we are able to do that, and this was very highly popularized by Professor Vicini, and everybody right now is mostly into this. The logic behind that being very simple, that you have the muscle that gets taken onto a very rigid structure on the lateralmost part and the entire muscle. Now, this is important to understand when I say this, that this is the entire muscle here that has to be picked up, and the entire muscle is taken in a vertical direction onto the pterygomandibular raphe. There are a lot of people, a lot of variants that were coming up, or people do, where they cut the palatopharyngeus here horizontally, and then they pull that up and take that upper part, or rather the cranial part of the palatopharyngeus, and hook it onto the pterygomandibular raphe or the pterygoid hamillus. Now, here is what we need to understand, that if you take only the upper 1/3 or upper half of the palatopharyngeus, you are not addressing the lower lateral walls of the pharynx. The lower lateral collapse is not being addressed with that kind of a procedure. So if at all you need to do some lateral wall expansion, you need to make sure that it's the entire palatopharyngeus that's coming onto the pterygomandibular raphe. And the selection now has become extremely methodical. Nobody speaks about, in my experience, or this is how it works and this is how I do it. But you have to go with an algorithm. Everything is getting evidence-based. This is an algorithm that I have proposed, which is for much more detailed explanations later on. But it tells you clearly that if you have a vertical palate with an AP collapse, you can just go ahead with a somnoplasty. You have an oblique palate with an AP collapse, you can do an anteropalatoplasty. But the major issues are when you have a lateral wall collapse, and that's where the thickness or the muscle of the palatopharyngeus comes into the picture. Because if you have it thin, you are not going to be able to pull it all the way till too far in the thickness. But if you have a thick one, you can get it and hook it onto the pterygomandibular raphe. But otherwise, you're going to have to use the relocation of the barbed if you have a thin muscle. And like I said, if you have a very thick palate, then zeta is the way to go. There is an issue with the upper and the lower tongue base. Unfortunately, there is no anatomical line that delineates the upper and the lower tongue base. But if you look at the lower end of your mentis or the mandible, and a straight line from there to the posterior pharyngeal wall, on that level is where we kind of visually, not anatomically, but visually delineate the upper tongue base and the lower tongue base. So if you have an upper tongue base, it is logical to think that you will have to go intraorally and access it. And if you have a lower tongue base, it stands to logic that you might as well do something on the external part over here, like a hyoid suspension, and then you're able to pull that tongue base anteriorly. So there is really not that much to think about. It's a visual evaluation over here, and it's the access that is available on the upper part and on the lower part. So that's where the controversies come to rest, but the decision also is a lot based on the patient profile, the other comorbidities that he has, the informed consent, and the way you explain and talk about the results that you're likely to get with one procedure on the tongue, and the backup facility that you have along with your training skills and whatever else you have. Now, a very, very important topic here, which I don't put up too many slides on, but I talk on, is the fact that the PAP therapy, though gold standard by the physicians, and this is in literature, but their own literature gives you a PAP failure rate of 50%. Yes, you heard me right, in the range of 45 to 55%. And this comes in two forms. There is an initial lack of uptake of the CPAP machines, and there is a long-term compliance rate that decreases over a period of time. So both ways, their rates that they have quoted in literature are in the range of 45 to 50%. And that is in fact the same figure that has been thrown upon us as surgeons to say that your surgeries over a couple of years tend to fail, because obviously we as surgeons understand that whatever you do to the muscle, it is going to lose its tonicity over a period of time because you have moved it from its origin and insertion. And at the same time, because with aging time, you are going to lose that tonicity. So if you have comparable rates of failure with the PAP and failure of surgery over a period of time, doesn't it stand to reason that if I can do a simple oropharyngeal surgery, and when I use the word simple, I mean simple, because even a freshly passed out candidate or a first year resident is able to do oropharyngeal surgeries very easily. And if by doing that oropharyngeal surgery, if you are able to give the patient, let's say, a CPAP free period of 5 years or 6 years, then you have done justice with that simple surgery that you have done. It's like otherwise saying to people that if I do a stapes surgery, my patient is never going to get an SN loss. We all are aware that 7 years, 10 years down the line, there is going to be some SN component that will come in and the patient will require a hearing aid then. But at the same time, you've managed to give that patient a 10-year hearing aid free period. And if you can do that as simply as not even that skillful surgery as a stapes. Stapes requires a lot of skill. Maybe an oropharyngeal surgery is not that skillful. But if you can get away with that, then why not? So this is the reasoning that you need to understand for the 90% of the surgeons doing 90% of the work across 90% of the country who are still probably not convinced about the fact that OSA surgeries can do wonders to the patient's quality of life. The other issue that you need to deal with is single stage multi-level surgery versus a single level multi-stage surgery. So I am a very strong proponent of single level multi-stage surgery, and there is merit in waiting always, because over a period of time when you stage your surgeries, there is a very, very good chance that you will probably have to do less over a period of time, and you have a long-term follow-up of that patient also. Whereas with the changing times and with the medical tourism that has come in, and there are people who travel to you from across cities nowadays, that those kind of patients, sometimes it is always more prudent to try and see if you can achieve something in a single stage multi-level surgery. But having said that, that has to come with a very, very proper understanding of the pathophysiology and safety measures when you're doing airway surgeries. A single level multi-stage surgery always helps us in having a very, very good long-term follow-up and keeping that patient. You will realize that it does give them better results rather than just a single stage staged event. Now, we all are doing surgeries with coblation now. So adenoidectomy is not such a big deal. There are people across the country now who are doing adenoid surgeries in 1-year-old kids, 1.5-year-old kids also. My lowest has probably been just a 2.5 or 2 year, 7-month child, but I know of so many people who are doing it under 2 years also. But the question here that you have to answer to yourself is, do you really operate on a non-comorbid child, although you have proven him to be on large adenoids, either on an X-ray or on a scopy? And the answer to that is a very, very simple yes, because if you can manage to do that, and if the patient has a pediatric OSA and not just allergic issues, then you are able to reverse a lot of these neurocognitive outcomes, as has been proven with a lot of meta-analysis and systemic reviews. And they have come to a kind of a borderline conclusion that the average age should be somewhere in the range of 6 to 7 plus or minus 1 year here and there. So it makes sense with the present tools to be able to operate early in a pediatric OSA patient. I use the words very specifically, pediatric OSA patients. Now, the barb suture pharyngoplasty is the big fad that has happened, and it's very easy for everybody to do for the shortage of time that was allotted, and we have other stalwarts also along the way. I'm just going to tell you that there is a relatively small sample size as yet also. And that's because everybody tries to do things differently. And as a result, we don't get one surgery in huge numbers. And that's what I've been trying to request people to do, that such simple surgeries can be done at different centers in huge numbers together. And then we are able, India is a country where you can get out literature and data way better than any of the other countries in the world. But we need a standard SOP or a standard operating protocol to decide on the kind of surgeries that will give the results. So this is a very simple surgery to do. I'm not going to get into too much details. You can see the pickup of the palatopharyngeus muscle that will be used with a barbed wire and attached onto the pterygomandibular raphe. The external approaches of the tongue base are restricted mainly to the bony cage abnormalities. You need to understand that there's lots that can happen over there. There's a lot of maxillofacial people and the orofacial people who are coming into this field. And that's where we have a little backseat, but we can coordinate with them and get them done. Never miss out on the epiglottis. Epiglottis becomes very important. Epiglottopexy is a technically difficult surgery as compared to the rest of the oropharyngeal surgeries. But yes, there are ways where you can do a kind of a bulgarization of the epiglottis onto the base of the tongue, or you can actually try to suture it to the base of the tongue. But yes, technically difficult, the suturing part. As a different case, I won't get into that. I would like to come to the choice of procedures being very importantly, as a lot of us, you may have heard on the dioceses across the country, when we speak of any procedure, we always talk about the patient, in inverted commas, earning your surgery. You do not go on to patient demand and you do not subject yourself to patient pressure. So the patient somewhere along the way has to earn their surgery, and that will only come if you find out whether they are motivated enough, even though they are educated. If they are motivated enough to lose a couple of kilos in a slightly higher BMI, then you know this patient is going to do well, and these are good patients for you to be touching. Socioeconomic status, obviously not from the point of view of the money, but because of where they come from, because the rural parts of India will never really come forward with this kind of complaints to you. And follow-up issues, obviously, because if they are from out of town and you have less follow-up, then your choice of procedure may rather tilt towards a single stage multi-level procedure. Of course, based on where you find the collapse and where you find the level of obstruction, that's how you decide. And not only just the patient factors, but also the surgeon factor, where your intricate knowledge of the pathophysiology and your training becomes extremely important. Equipment is not that really necessary because a lot of things can be done without sophisticated equipment, but you need to have very good backup facilities. And at the same time, you need to understand it's that the patient has to be willing to take the risk, not you. And the trends are definitely changing over the world where you are moving from the invasive to the non-invasive work. About 2007, when I first gave my talk on OSA somewhere in the country, it was Aurangabad, then Nasik, and then Kolhapur, and then Chennai. So hypoglossal stimulator was the last slide which I used to keep as future in India. And I used to say, this is the next big thing that is happening. 14, 15 years down the line, this still remains my last slide because they have really not moved forward across the world for reasons of cost, for reasons of FDA, for whatever you may call it. And I really don't think that they're going to come back into the country or come back into the field so early. But yes, for completing a kind of a OSA situation, hypoglossal stimulators become very important. We need to do a lot of research on the different type of procedure and results, where we have also been trying to give out fellowships and training programs and talk to the legislative authorities, mainly to get it sanctioned by the insurance companies. So ladies and gentlemen and all my friends, here's a few take-home messages where just the AHI normalization is not our goal. That's not what we are looking at when we're doing AHI surgeries. So be convinced that OSA surgeries do well. Don't go by maybe a physician's criteria to tell you that an AHI has not come under control and so your surgery has been a failure. At the same time, your endpoint should not be the AHI, but a safe and happy patient, safe being more important, happy, of course, and the bed partner, and you have to have a long-term approach. And even a partial improvement in bringing down the, bettering the quality of life of the patient can make so much of a difference. But here's a little parting thought for food of thought. So when I'm doing this, when I'm doing a DICE, what am I really doing this for? When I gave it a lot of thought, did the PSG really make a difference to my thought process in changing my treatment protocol? The answer that I got was a no, a clear-cut no. So maybe I realized that all I was doing this for was to go better up on a chest physician or a non-ENT dais and say to them, okay, listen, that was your objection to me doing a DICE, and here I'm getting rid of the obstruction. But frankly speaking, let me tell you, I don't think this is needed at all. And in fact, coming to that DICE part of it, which I was trying to tell you, there is something that I keep telling everybody, that if you have a lateral collapse on a flexible awake scopy, and maybe it's 20-30%, we are all very clearly aware that this collapse is going to get worse when you do DICE. You will see a definitely more, a worse collapse when the patient is asleep and under anesthesia. But does that change my decision making? When I have seen it in the awake scopy, am I not going to be addressing that? Or is there some criteria that tells me that, okay, 20% lateral collapse is not to be touched, but if it is more than 40% lateral collapse, then it has to be touched. So when I'm going to see a 20 to 30% also lateral wall collapse in an awake situation, and I am going to touch that, then why am I insisting so much on a DICE, which obviously, yes, it will give us a different picture slightly, but does it really make that much of a difference to my decision making? So does that playing around with the palatopharyngeus, is that the only thing that makes a difference to the long-term outcomes? No. This is what people have to understand, that it's not just that oropharyngeal little surgeries that play around with the palatopharyngeus, but we have to be on the same page and evaluating the patient thoroughly and coming on the same page for operating protocols, because whatever we do have limitations to understand that this is the part where an ENT surgeon comes in, not any of these parts. But if the ENT surgeon does not understand any of these parts, you're probably going to fail in even the best of the things that you do in this part. So this role of the sleep apnea surgeon is extremely important. And if you realize that understanding the pathophysiology of OSA, does that translate into better surgical results? Most definitely, yes. I can put this down with conviction that it definitely does, because that's how you're able to give the better results to the patient. So thank you everyone for a patient listening. I would be open to any questions across the way because before the other surgeries start. I always part with saying that the more you know, you realize how much you don't know, but the less you know, you really talk a lot more. So maybe I was harping a lot more 15 years back, as much as I don't do now, because now we tend to know a little bit more about the pathophysiology. So thank you very much for that patient listening. And I'm sure you all enjoyed it
Seemab,
along the way. Yes, sir.
yeah, we are also very happy that we want our patients to be safe first.
Sir,
and then happy
absolutely. In
next.
fact, I was wanting to try and get into the post-op extubation of your patient, but for want of time, I didn't intervene and I said, let's not get there. That patient would have been very wonderful to be extubated and shown.
No, honestly, what happened was because of too many centers being connected,
Absolutely, sir.
I couldn't hear your questions properly. The audio today was a little bit, probably because too many centers being connected. Half the questions I couldn't hear.
No,
It's not that I didn't want to answer, but the audio ones wo nahi sunai deta to thoda.
Bilkul, sir, and as being organizers with all of you, we understand constraints, so we don't want to unnecessarily.
42 centers across India to be connected by this land.
Huge, sir.
And technically, even with the best efforts, Alembic also. Sometimes, these are technical. So, but it's a pleasure, Seemab.
Thank you, sir.
Always to listen to you because you balance both well.
Thank you, sir.
Not the cavalier, we'll operate for everything types. So I've always liked you, your presentations, your humility, the way you present. Thank you very much, Chief.
Thank you very much, sir. Thank you. Thank you for having me here, sir.